everybody, and welcome to Master Series Topical Oxygen Therapy. Thank you for joining us today. We have an excellent 60 minutes of packed session with some global wound experts joining us. And here is our panel tonight.
I'm a vascular surgeon here at NYU Langone, Brooklyn, and I've been here for a little over 20 years. And we've been interested in wound healing, lower extremity arterial revascularization, and venous disease for a number of years.
I feel privileged to be with this esteemed panel. I am overall a patient advocate. I'm a therapist. I'm also a wound specialist and lymphedema therapist. And for 32 years, I just based my practice on helping that patient and looking what else we have in our arsenal to move that needle. So I work across the continuum of care, and I'm thrilled to be with this panel.
I'm a podiatrist practicing in Chicago. Most of my career has been both in private practice and in the Veterans Administration setting, where I've been a residency director and taught residents and students surgery, wound care, all that. In the VA, we had the opportunity to use a variety of different products on our veterans with great success. So I've been in leadership also, president of the American Podiatric Medical Association, the International Federation of Podiatrists. And most recently, I've decided to join AOTI as their chief medical officer, kind of on the other side of the fence from where I've been my entire career, but it's been a fascinating experience.
I'm a vascular surgeon working in East Brooklyn, and have a very mixed practice from venous disease to arterial disease. And a big portion of that is tibial disease, which is non-reconstructible or very difficult to reconstruct, associated with lower extremity wounds. And I've become familiar then with topical wound oxygen as an augmentation for wound healing, and particularly for recalcitrant wounds.
I am a family nurse practitioner. I've been in wound care for about 20 years. Right now, I am the director of wound care services at the George Washington University Hospital in Washington, D.C., overseeing all inpatient and outpatient wound care activities. I have worked with topical oxygen for over 10 years.
Welcome to our global panel. Thank you very much for joining us today.
Thank you. It's my pleasure. This is quite an honor to be with this group.
Thank you for inviting me.
Thank you very much for having me.
Thank you very much for having me.
Thank you so much for the kind invitation. I'm really pleased to be part of this panel.
Wound Masterclass Academy has a series of 60-minute interactive immersive sessions coming up. Thank you very much for joining us on the November 17th Master Series, which was on pressure injury prevention. If you would like to see this session, if you missed it at the time, please click on the on demand on your screen now, and you can actually save that video to watch. And that was the event on November 17th. Now, the event we have tonight is a great program. It's talking about topical oxygen therapy and how you can introduce it into your practice. It tells you it from the beginning, basically the basics of oxygen and wound healing. And then we go into an in-depth look at how to use the technology, what kind of patients we can use them in, and also any tips and tricks for improving oxygen therapy for patients in clinical practice. And then during this 60 minutes, we have a live Q&A session. So please interact with us on the chat. And the screen has also got the virtual exhibitors hall, which you can go into after the session's finished and sort of get to know some of our exhibitors, pick up any papers, documents, key papers. Any key papers that we discuss, we will link into the chat below. And so thank you for staying tuned with us, and we really look forward to spending the next 60 minutes with you. So let's start by finding out what the role of oxygen is in wound healing. And anyone in the panel like to tackle this question? So on a molecular level, how is oxygen improving wound healing? And, you know, for our viewers and readers and subscribers that are out there, we sort of want to know what kind of conditions are we thinking that oxygen may improve. So what kind of wounds does oxygen improve? For instance, radiotherapy wounds, is that something that we can use oxygen to try and help heal? Or are there any other types of scenarios that oxygen can assist in healing? So let's go to Dr. G. Can I come to you on this one?
We've been able to treat a variety of different wounds, from radiation burns which have been very difficult to treat in the past. Patients with sickle cell, we are now treating those patients with this technology, and they've always had a problem healing wounds. And pyoderma gangrenosum, that has been very difficult to treat. We now have many, many success stories in using topical oxygen to treat these very difficult to heal wounds. So indeed, we are making a difference at the molecular level, changing the way the cells function and the way they communicate to each other, and therefore allowing healing to finally occur in these difficult to heal wounds.
Oh, so the scope for the wounds that can be amenable to oxygen therapy is quite wide from what you say then, Dr. Garoufalis. So there still remains, a large percentage of the population, clinicians, nurses, and hyperbaric technicians, basically wound care professionals involved in treatment of patients. There seems to still be a bit of a reluctance to incorporate oxygen into their clinical practice as part of an advanced modality to be used alongside standard of care, doing the dressings that they're normally doing and the wound cleaning preparation, etc. So just a question to the panel, why do you think there is this reluctance to incorporate oxygen into clinical practice from those clinicians?
I think part of it is because of the experience with the hyperbaric chambers has been fairly traumatic to some of the clinicians, not only the patients. When we've been dealing with hyperbaric oxygen in the chambers for over 20 years at our center, and I think it did help the wounds, but there are severe complications also associated with tension pneumothorax due to bleb disease in the lungs. So we used to screen all the patients before putting them in the chamber for a chest x-ray. The hypoglycemia in some of our diabetic patients that could be induced with chamber-based oxygen was always a problem, because some of our patients that in the early morning shift at 5 o'clock in the morning, their sugars may not be so great, and you have to dive them. And if their sugars are 80, they're really too low to be safely brought into the chamber, because you can't really bring them back up so easily. I think there have been also problems with barotrauma to the tympanic membrane. So we do have a long experience with chamber-based oxygen being, and its systemic and local complications. Besides the cost is a major problem. The local home-based therapies were really preferable for many of our elderly patients who coming into the center a couple of times a week was really inconvenient. It was not really helpful. And I think also the cost was a major problem for the insurance company. So we had several levels of problems with the previous experience that really turned a lot of our patients and a lot of our clinicians off of chamber-based hyperbaric oxygen.
I travel the country, and when I look at the data as a therapist, we want to treat those chronic wounds, and I look at modalities. So there was a study way back then, and I haven't seen a repeat study, that shows that 80% of the clinicians treating lower extremity wounds do not know what advanced modalities are. And so when you start looking at, or selection of products, we just don't know what's out there. So we're reluctant to bring anything new because of our lack of knowledge.
So interesting, Frank. You and I have had some discussions before about this, the history of oxygen in wound healing therapy. Are you able to give our viewers that are watching just an overview of historically how oxygen came into play for treating some of these wound conditions, just so they can understand a little bit about the past? And obviously, we're moving forward to try and see the application of oxygen for other wound care conditions. And also, before I ask that, don't forget to interact with us in the chat if you have any questions to any of the speakers. And now is the best opportunity to use that text chat, and we'll answer those questions as we're going along. So over to you, Frank.
Well, oxygen, of course, hyperbaric was prominent back in the 60s. And we know the importance of oxygen is vital to sustain life, but also we know that after you have an injury, the vasculature will limit the oxygen to the area. Now, having a hypoxic wound is needed, and that's acute hypoxia, because that's what starts some of the processes. But when you have inflammation, key makers, that's going to increase the oxygen demand. So if you have prolonged hypoxia, that wound's going to not move to the proliferative phase. So I changed the way I practice because I look at oxygen, not only with ischemia, not only perfusion, but like people with lymphedema, I'm looking at diffusion. Is that oxygen getting to the actual site? And I have technology that's able to prove that. And so oxygen becomes very important, not only to get to the area, but then the second component is inflammation, which I mentioned. All the wounds are in the inflammatory phase. So we know that oxygen helps with taking care of bacteria. We know that it helps with angiogenesis. But if we have this hypoxic wound, we're not going to progress. And lastly, the third thing I talk about is nutrition, cell health, which means that if we don't have the necessary nutrients and the oxygen getting to the cell, then we're going to have a very inactive metabolic cell. So to move the needle with oxygen, topical oxygen just got a bad rep from the beginning because there were poor studies, which we can go over later, but the evidence is significant now to show how it can help with everything I just talked about. And when you use it, you know, I'm going to tell you that we all have biases. And so when a patient comes in, we're biased against a lot of modalities. But when you see this working, it will change the way you practice.
Oh, interesting, Frank. Yes, you make a mention of obviously advanced technologies, and I'm assuming that you're referring to thermography here for measuring actual oxygenation patterns or levels in tissues. So, I mean, I would suppose that would have a big impact on design of future trials, because we'd have obviously access to these advanced modalities to use to measure how well wounds or tissues are being oxygenated, and there'd be an actual sort of objective measurement rather than a subjective measurement in relation to wound size and healing times and speeds, etc. So that's really interesting, and I suppose in designing future trials that will be relevant. So we will possibly discuss that a bit later on. And if anyone in the audience has any comments or any questions, please interact with us on the chat throughout this 60 minutes. And then I guess a question that most of our viewers would like to know is, how is oxygen delivered to the wound? So what are the different methods or the different ways in which oxygen delivery can take place? So who would like to come and answer that question from the panel?
Basically, there's right now for topical oxygen, there's continuous diffusion oxygen, which has been around for a little while in a variety of different devices. And then there is cyclical pressurized topical oxygen, which is the newer technology, been around for about 10 years now. And that actually drives oxygen into the wound under pressure. So and that's how I first got involved with topical oxygen. I had used many of these devices in the past and with an understanding of hyperbarics, but not always having access to that. And in my hands did not get sustainable or consistent results. So when the cyclical pressurized topical oxygen became available, I was interested in it from a scientific point of view because I understood the theories behind it, oxygen under pressure, the non-contact compression. I understood that from lymphedema and from venous stasis treatment. So even though there was still no science, this was back in 2015, there still wasn't any real good science available. I understood the theories and started using this modality in my practice. So basically today, we still have those continuous diffusion devices, which now have some very good studies. And we do have the cyclical pressurized topical oxygen, which now has level 1A RCTs and excellent studies. And they've all been reviewed and accepted into medical literature. And so we're in a much better position today than we were many years ago.
It's really amazing. It just goes to show that in a space of a few years, how much progress we can make in a subfield of wound care, essentially. And, you know, this is part of the reason why we're so honored to bring you these master series, 60 minutes interactive immersive, is because it's essentially taking an in-depth look at key specialized subjects with the best global experts telling us, all the evidence that we need to know to try and convert these key technological advances into everyday clinical practice. And it's all evidence-based. And as you know, this particular subject, I guess topical oxygen, has a strong background of evidence supporting all of its conclusions that we're discussing tonight. And I think that probably leads us into just exploring a little bit about one particular condition, which I suppose most of you watching this and most of our viewers, you'll be on the front line of managing diabetic foot ulcerations, and unfortunately some of those progressing on to amputations. So it's obviously a very key clinical condition to get right early on to try and prevent obviously these terrible amputation situations. So let's have a little look at some of the evidence base behind topical oxygen and diabetic foot ulceration treatments. So let's go to Dr. Garoufalis. Let's see if we can have a summary of that.
As I stated earlier, there's been now a plethora of articles done over the past 4 to 5 years that have come forward, been peer reviewed and published. Two studies that I want to review on cyclical pressurized topical oxygen is the RCT that was published in Diabetes Care. The RCT was able to demonstrate using this modality that we were able to heal wounds 6 times faster in 12 weeks and had reoccurrence times of 6 times lower at 1 year than the study arm that did not get topical oxygen. So that was remarkable data right there. We then had a real world evidence study that was done in a VA population. And for most everybody understands that the VA population is loaded with comorbidities, and these folks suffer quite a bit and have a lot of issues going on all at the same time. With this real world evidence study, we wanted this study because, people say in an RCT, well, I don't see those types of wounds. I see more severe patients in my practice. So we wanted a study using the most severe patients we could find. And we did that in the VA, looking multi-site, 2 different VAs, over 200 patients. One arm got oxygen therapy, cyclical pressurized topical oxygen. The other arm did not. Everybody, all the patients in the study were undergoing regular treatments for their wounds using skin substitutes and grafts and different dressings. So they were all using top line modalities to heal their wounds. The only difference in the study is one arm got oxygen therapy, the other arm did not. And we even had patients that were on dialysis, had kidney failure. So we had a pretty comorbid group. What we were able to demonstrate in the real world study is over 80% reduction in hospitalizations after 1 year and over 70% reduction in amputations in 1 year in the group that got oxygen therapy. So this tells us that we have a modality here that can make a difference in patients' lives and make a difference in costs. So this paper had a little cost formula attached to it so that we could take the results from this study and put them into different healthcare systems and estimate what the cost savings would be to that system based on their diabetic population and their diabetic ulcer population, and show them what savings they could see in the terms of billions of dollars typically by using this modality. So we now have data both in the continuous diffusion world and in cyclical pressurized topical oxygen that is definitive. It has been peer reviewed, and it has gone under meta-analysis by several different groups, all extremely very positive. That being said, I probably should mention that the RCT that was published in Diabetes Care was just recognized by the International Symposium on the Diabetic Foot as one of the 4 top research studies in the diabetic foot in the past 4 years. Before, we were totally devoid of information. Now we've reached a pinnacle, and we have a modality that is here to stay and demonstrated that we can make a difference in patients' lives.
Oh yes, and real world data was key during the pandemic when obviously organized trials were unable to go ahead. So I guess for the viewers that are watching, those who don't know what real world data is and how it differs, I guess it's observational data. So it's gleaned from electronic health records, outpatient visits, inpatient clinic visits, and that information is gathered and conclusions are drawn from that, rather than having an organized clinical trial like a randomized controlled trial. And I suppose that sort of method of data collection and conducting trials really had its best moments during the pandemic, because that's when a lot of companies, a lot of researchers moved over to that style of data gathering to try and draw any conclusions. And let's go to Dr. Hingorani next, and just the question about how do we think that translating that clinical evidence that we've seen presented, how do we translate that into clinical practice? I suppose the question is, what types of patients are you in your practical clinical practice are you using topical oxygen for?
When we first were introduced to this, we were very, very skeptical of the technology. And we actually were not very enthusiastic because of the prior experience that we've had. So we decided on some of our more difficult patients, the patients with long-standing wounds that we had already tried everything. We had revascularized them. We had go ahead and fix their veins. We had optimized their wound care, and they still continued to have wounds, and they were persistent and quite unhappy with us and our medical system. Despite our best attempts in throwing in everything, including the kitchen sink, these wounds persisted. And often these are patients who were referred to us from other clinicians. So these patients already knew their way around, and they already had longstanding ulcers. So we decided on a few patients, we have nothing else to lose, let's try this. And as Dr. Garoufalis was saying, if you try it, I think you'll be very, very surprised at how well it works. We were amazed. Within 5 weeks, some of these patients were turned around. One of the earliest signs that we saw was a reduction in the tissue edema and the pain. So that was getting back to what you had mentioned earlier in terms of the cyclical oxygen, in terms of the compression. I think that's actually an underappreciated cause of non-healing wounds. Even in arterial wounds, we get a little bit of swelling and we just attribute it to inflammation. I actually think that it may contribute to the non-healing of the wound. And I think if you have that compression, cyclical compression, it's quite light. It's only 30 millimeters of mercury, and it's only for a short period of time during the day. It's only 90 minutes in contrast to the continuous diffusion oxygen. The patients start to say within a few weeks that they're feeling better. Their pain is getting better. And of course, you see the wounds getting better. So that's where we started. However, here in the US, we have quite a large array of patients that we are approved for using these wounds. Specifically, acute and chronic wounds greater than 30 days old, patients who have ulcerations due to diabetes, venous stasis ulcers, post-surgical wounds, which I think is actually very, very important because those post-surgical wounds, transmetatarsal amputations that aren't healing, below the knee amputation wounds that aren't healing, can be very, very difficult, and they're very, very common problems. Post-surgical infections, gangrenous lesions, decubitus ulcers, skin grafts, burns, and frostbite. Quite frankly, this covers almost all of the patients that we would see with chronic, difficult to heal wounds, at least in our practice. So the application of the technology is quite broad, and I think that's one of the advantages of this particular technology. Even if the patient has significant infection, this helps in fight infection. We mentioned it earlier that the oxygen is toxic to these bacteria, and we have evidence in the studies that Garoufalis had mentioned before that infection is better with these patients in terms of wound cultures.
Okay, so Dr. Hingorani, you're mentioning that patients are presenting late, especially diabetic foot ulceration patients. So let me just ask the panel, how can we facilitate an earlier management of these patients? I mean, what are the reasons behind specialists like yourselves seeing these patients later than you would ideally like? So anyone in the panel like to tackle this question?
I think that we're reluctant Again, we only know what we know. I really see having that bias. And as Dr. Hingorani said, these are the patients that when a new product comes in, we're going to use it on the worst of the worst. 12-year ulcer, expecting a return right away. But I do want to say that when you start looking at actually the research, because the first thing I hear is, how is oxygen getting there? But when you look at it, there was a study done and it showed that at 2 millimeters, the oxygen, which we talked about being high, we talked about the wound being hypoxic. Now at 10 millimeters of mercury measured, we know that's not conducive for healing. And after 4 minutes of topical oxygen, that number went up to 40 millimeters of mercury. And so when you start showing the data, you asked me about lymphatics and venous wounds. I got a working hypothesis, but when you look clinically, these patients, the pain is decreased and also the drainage is decreased. So now we are affecting, in my opinion, the lymphatic system and the venous system, because that's where it lies. And so we're not using this in our clinics because we don't think about it. We're still thinking that topical oxygen is voodoo. But when you try it, like the whole panel have said, it's amazing what you can find.
Interesting points about bias, Frank, and I suppose that exists, and it's something that needs to be challenged a little bit to try and move forward and be open to advanced modalities being used in clinical practice. One important topic is obviously how do we assess the limb of these patients that are about to undergo topical oxygen therapy. So who would like to go through limb assessment and patient selection with me from the panel?
When we have a patient come in and we're interested in getting started on treating a patient with whatever modalities we're going to use, of course, we have to make sure that they have adequate blood flow, that the wound has been debrided adequately, that they're relatively free of infection. I mean, the bacteria is going to be there, but if we can control the purulence and get that under control, we're in good shape. And then we can start therapy. And traditionally, what we've started is with the 4-week model of good wound care. We started with good standard of care medicine, which would be, a topical dressing, like a collagen or a foam or something like that, and have the patient back and measure how the wound would decrease in size. And hopefully at 4 weeks, it would be decreased in size by 50%. And we can continue doing what we're doing. If at 4 weeks it has not decreased in size by 50%, we have to up our game. We have to go to different modalities, such as skin substitutes or something like that. Now, topical oxygen being an adjunctive therapy can be used at that 4-week level as an adjunctive therapy. However, those of us that have used it and see how effective it is in treating these wounds are very encouraged in using it right off the bat. As soon as we start treating the patient, not only are we treating them with a standard of care, but we also would like to treat them with topical oxygen initially. And in many of the patients that I started initially with topical oxygen, instead of waiting that 4 weeks, made a huge difference in their recovery times and in the way that wound closed, because we're able to affect that hypoxic level of that chronic wound very quickly early on, and then have to wait for the 4 weeks. So again, it's very much up to the payers in the wound healing cascade that we have to deal with. Ideally, we like to start this off initially as soon as the patient comes to us with that wound, but often the payers may say you have to wait 30 days and then you can start this technology. But wound assessment is key because you have to pick the right wound. I mean, many of these folks have to go to revascularization before you can even start treating the wound in order to make sure that there's enough blood supply to heal the wound. So wound assessment is key. Wound bed preparation is key. All very important factors in getting that wound off on the road to getting it healed.
What a great overview that was of limb assessment. So thank you for that. That'll be very helpful for the viewers. So can I ask the panel as a whole, are there any clinical scenarios in which you would not use oxygen, or any types of patients you would say definitely not going to use oxygen in this clinical situation?
One of the contraindications, because there is a cyclical pressure exerted by this technology, is that they have an acute DVT. You probably should not be using compression, and specifically the cyclical oxygen therapy. I would probably be reticent. All of our patients get screened before we start them on oxygen therapy. But I just want to get back to what Dr. Garoufalis was saying. This is an adjunctive technique to what you're already doing. You're already assessing the arteries, you're already assessing the veins, you're already assessing the local wound care, you're already assessing for infection. This adds to what you're already doing and augments the healing. So that's the reason why I think it's important. It doesn't change what you're doing. The sleeve fits over all the other types of dressing changes, from skin grafts that you're putting on, skin substitutes, to compressive dressings, to a total contact clasp, all the way up to the knee. So I have some patients that have wounds up to their knees, and they're a challenge. This still is applicable for those patients because it goes all the way up.
This is one of the misconceptions with the early topical oxygen. And so we shouldn't be treating patients with osteomyelitis with topical oxygen because I hear from hyperbaric, the hyperbaric oral, because they think that topical oxygen treats it, and it does not.
Oh, thank you, Anil and Frank, for that clarification. That's really helpful to know. So I think we'll come to Kara Couch next, just to ask you, Kara, what sort of patients in your practice, you're in a busy center in Washington, D.C., what sort of patients are you typically using oxygen therapy on?
So we use it on, we do hyperbaric oxygen here, of course, but also there's, I think, great opportunity to use it for lower extremity wounds. And as I mentioned, I've also used it on upper extremity wounds to help with digital ischemia for patients that I cannot bring down to the chamber because they're, in the intensive care unit or what have you. So, there's a wide variety. I think that the key with using topical oxygen is you need a committed patient, so that if they're using it on the outpatient setting, they're doing it consistently, so that you can ensure that the therapy is being done daily or as prescribed. But, it's similar to other technologies in wound care where, they are fantastic, but you have to choose the patients appropriately to ensure the best outcome.
Right, so quite an interesting practice with the ICU wound situation as well. And Kara, are there any situations where you would consider using prophylactic topical oxygen therapy? Any sort of situations?
Yes, definitely. I think that we have opportunity to assist the patients that get digital ischemia from pressors when they're in the intensive care unit. So we are about to start a trial on that, specifically looking at the hands. It's obviously any level of amputation is horrible for patients, but particularly when you think about the upper extremities, the prosthetic technology just has not caught up as much. And so those patients have a much more challenging time than a lower extremity amputation. So that's one option. Another area would be patients that suffer from Raynaud syndrome, similar to, that where it would help them, particularly in the winter time. Those are patients that we sometimes bring into the hospital for IV Flolan for 5 days, but this would be a much preferable treatment to do outpatient at home with them to help with it, and another very painful condition which can result in horrible wounds.
So Dr. Hazar, as a vascular surgeon, what kind of patients are you finding are benefiting from topical oxygen therapy in terms of pain levels? So you're seeing quite a lot of patients that have pain secondary to ischemia, and a lot of wounds obviously secondary to ischemia. So which types of patients are you finding are responding best to topical oxygen therapy?
One of the great sort of, I guess, secondary effects of the topical wound oxygen, aside from wound healing, is that it does show a marked reduction in pain. And so we've had a really great response or compliance, I will say, with the patients doing this. One, it's very easy to use. It's actually quite comfortable for most of the patients, even those who have wounds, because they find that their wound now hurts a lot less. And sort of reinforcing that with the patients has been a big benefit. Any patient, as people have described in the past in the papers, that it hasn't healed a wound for 30 days is definitely one that we consider, in particular those who are diabetic or who have otherwise non-revascularizable ischemic issues, or kind of even a mixed arterial and venous disease, or arterial, venous, and lymphatic, which we have in some of our patients. Right now, we are limited in terms of insurance reimbursement in the United States, in terms of having to qualify for a certain amount of time. But I do think at some point down the road, we might look at a certain group of patients and say, you know, we're going to start this immediately, because it's a helpful adjunct to the other things we're doing.
Thank you to our viewers who've, stuck with us for the last 40 minutes or so. And thanks again to this amazing global panel who've, shared their expertise with us. We've got a really exciting short segment on Q&A coming up now. So continue to ask your questions in that live chat. Just need to press the chat button on your screen, and we can tackle any questions with this panel. So one question coming through will be about costing. So is there anyone that wants to tell us a little bit about sort of how this is paid for, particularly in North America, in terms of CMS, Medicaid, Medicare, private insurers? It seems to be a real challenging situation in order to get this coverage and a payment for this modality. So who would like to tackle that question?
Right now, the coverage in the US is only in the VA setting, the Veterans Administration. And in New York, it's covered by Medicaid. That, however, will soon be changing, as Medicaid in other states will begin paying for it, hopefully in the new year. And also, we hope that CMS will come around and allow it to be covered by CMS, at which point we think that not only will we have CMS coverage and Medicaid coverage, but the private insurers will then fall in line too. Hopefully, all that will happen in the new year. But as of this point where we are right now, it's the VA and New York Medicaid primarily. Those folks that see community care patients from the VA in their practices can use this modality on those folks as well, because the VA is covering their health care.
So how long would a wound need to have been present for in order to be able to get this coverage that you've mentioned?
Right now, the most restrictive part of the coverage is in New York Medicaid, where the wound needs to be present for at least 30 days. And then it gets reassessed every 30 days, which is appropriate. But other than that, there are no other restraints on when and how this technology is used.
Oh, so we have a question about how does the technology work, and basically how does the device work? So I think Dr. Garoufalis, you've prepared a video for us to look at that in more detail.
Welcome to Advanced Oxygen Therapy's brief setup training video on the TWO2 therapy disposable system. You'll receive a 10-litre oxygen concentrator. On the back, there is a filter that should be washed weekly with warm soapy water. Central to topical wound oxygen therapy is the controller. The unit monitors the pressures and controls the therapy for the duration of the treatment. The power cord is attached to the bag and secured using a Phillips head screwdriver so that the cable is not accidentally removed. The oxygen supply hose is screwed in place on the side of the unit. The blue hose assembly is attached on the other side. The nebulizer cable is also attached on the same side as the blue hose assembly, lining up the red dot on the cable with the unit. When using humidification, attach the cable to the nebulizer cup and fill the cup with an ampule of sterile water. The disposable boot arrives in a box of 20 units. When the boot is unfolded, you will notice the rib area that inflates the boot first, the cuff area that seals the limb inside the boot, and a channel that reads the pressures within the cuff. In order for the correct pressure readings and proper boot inflation to occur, ensure the channel and the reinforced tab are kept free from kinks and bends. Line up the notch on the hose assembly with the notch on the boot and attach the hose. If you are not going to use humidification, use the cap to close the port. If humidification is used, attach the nebulizer cup to the port and ensure that the cup is facing upwards. Turn on the oxygen concentrator by pressing the toggle button at the front of the unit. Next, turn on the controller by pressing the top button. It will prompt you to inflate the bag. Press the bottom arrow to inflate the bag. Ensure the valve on the cuff is closed and put the limb inside the boot, just below the fold behind the knee. Continue to follow the prompts on the controller. Press the bottom arrow to inflate the cuff. Then press the bottom arrow again to start the therapy. The pressure in the boot is displayed on the screen, where it will cycle about 2.5 times a minute. While therapy is in progress, check there are no kinks or bends in the channel so that the therapy will not be interrupted. When 90 minutes of therapy are complete, the controller will beep and prompt you to stop the therapy. Turn off the controller by pressing the top button. Then turn off the oxygen concentrator by pressing the toggle button. Release the valve on the cuff so the limb can be comfortably removed from the boot. Then detach the hose assembly and the humidifier components, ready for the next use.
Thank you very much for showing us that instructional video, Dr. Garoufalis. Can I ask the panel what sort of specific technical challenges, such as compression stockings or compression wraps or total contact casting, how much of these have an effect on whether topical oxygen therapy can be used or not? Who would like to answer that?
Well, it certainly can be used with compression hosiery because oxygen can penetrate that. And I know that it's very challenging to put on and take off compression hosiery. So if the patient doesn't have to do that just to use this therapy, then we're ahead of the game. So they can use it over compression hosiery without a problem. We even use this technology if they have compression wraps on, such as a multi-layer compressive system or anything like that. And so it's not a problem at all. It can penetrate all those materials. I've used it in total contact casting many, many times. The larger boot was developed not only for venous stasis ulcers and the wraps that those patients wear, but also to accommodate a total contact cast. And so, we think we're doing a great job. We finally get a patient a total contact cast. Let's take it one step further and give them topical oxygen at the same time. And so we can use all the modalities at our fingertips then.
The only dressing that we would avoid using it with is a VAC dressing. So if there's a VAC on board, although I think down the road we'll figure out a way. I've talked to Dr. Garoufalis and a few others about, for the prescribed time, 45 minutes or so twice a day, reversing the flow of the VAC and pumping in oxygen, topical oxygen. That would be an awesome thing, but that'll be down the road. But for right now, we're limited in terms of that.
Actually been working on that also, and what we've been doing is shutting off the VAC for the 90 minutes while we put on the topical oxygen. So there are creative ways of combining the therapies, because some of our patients really do benefit from the vacuum dressings. But if you shut it off for 90 minutes, slip on the topical oxygen, and then go back after 90 minutes, it actually works out fairly well. So we've been using both. Just one thing to add for Dr. Garoufalis's topic: as long as the wound dressing is gas permeable, so the petroleum gauzes, I try not to use it with the petroleum gauze based dressing. So everything else, I think it's fair game.
So, question for the panel: which patients or which types of patients tend to respond best to oxygen therapy?
You're talking about compression, and this is what turned me on to topical oxygen. When we look at the venous leg ulcers that we have a high recurrence rate, and we also have a problem with healing them. And so when you look at the US wound registry, they say that 50% healing at 12 weeks is what you expect. But in other countries, we only heal about 43% of these wounds. So when you look at one of the studies that look at venous leg ulcers, they looked at patients with venous leg ulcers over 2 years with an inclusion of 1 year of no progress. Well, Margolis in 2004 said that if the wound, venous leg ulcer, is there for 12 months or bigger than 10 centimeters square, the chances of healing are 22%. And I see that in clinics. And this one study, they looked at venous leg ulcers for over 2 year duration. They had 76% healing rate at 12 weeks, which is better than what we see. But the other staggering result was the reoccurrence rate. It was only 6% in 36 months. So that told me what I mentioned before. If you look at oxygen, cell health, and inflammation, that your foundation. And so now you have a stable wound bed surface. It's not going to break open again. So anyway, that's the VLUs is terrific when it comes to oxygen. And Dr. Hasler, I'm going to tell you that we just applied it to a patient that has no other hope, and vascular path, venous path also. And in 2 days, his pain level decreased so much that he stopped taking, he was between 800 and 1,000 milligrams of ibuprofen. And then in 2 days, he stopped, and he said the pain is better. And this was validated with another study.
Thank you very much to all of you. And what would you say is the take-home message to the skeptics in the audience that are still reluctant to incorporate oxygen into their practice, topical oxygen? So what's the message you would give them after, having this discussion tonight?
So usually what I told them when I became a patient, and I told the doctor, I said, I want you to give me every choice available that we have, because if my wound doesn't get better, okay, then I could lose a limb. We all know that. So I asked him, leave your bias out and show me the evidence. And so his talk was a lot different.
I was the biggest skeptic in the world about topical oxygen. And until I started using this modality, cyclical pressurized topical oxygen, on a subset of 5 patients and realized the outcomes, I would have never believed that it was possible. And look, after many years of practice and using it on hundreds of patients, I've now decided to become the CMO of that company in order to, educate others on what this can do for their patients in their practice.
I would tell them maybe to read 1 or 2 of the papers that were really, truly excellent randomized controlled trials. I think they were set up extremely well, and the outcomes were really astoundingly different in terms of wound healing. But especially, I think what I found so compelling was the recurrence rate. The difference of, like 4% versus 70+% recurrence. And we see in our clinical practice exactly that. And I guess I can also take my own anecdote of one patient that I had scheduled for an angiogram. And while I was waiting to set up the angiogram with a very difficult heel ulcer, they came in 30 days past, and it was during the time of COVID. So there was a delay in getting them into the operating room, and the wound had healed. So I've really found in my own clinical practice a remarkable change in the healing patterns.
I think that one of the key advantages that I see to using this modality, and we've referenced it several times during this this great lecture, is the pain reduction that you get. I think we can't overemphasize how badly pain impacts quality of life. And if we can get these patients off of, even taking 1,000 milligrams of ibuprofen and Tylenol several times a day, like that's a lot for people to keep up with. And it really is a negative impact. And that was one of the most striking things that I noticed, in addition to the obvious healing benefits, was the rapid pain reduction, which, you can't buy that for patients. Like they're just so grateful and thrilled that that has happened, because it is so horrible that they're living with this pain.
I want to echo what the others have stated, because I think everything that they've stated has been not only accurate, but applied to us also. But also working here in South Brooklyn, we have a real problem with accessibility to care. And this home-based oxygen really makes a big difference for that, helping those patients who may not have access to other types of care. This is a home-based therapy that they control. And for our patients, it's actually worked out really, really well.
So Dr. Hingorani, how did you find the COVID pandemic affected your patient care?
Our patients didn't want to come to the hospital. They didn't want to come to a hyperbaric chamber. They didn't want to even come into our office. So having them have access to care at home was a big game changer for a lot of our patients. And quite frankly, seeing the wound healing, in addition to the randomized controlled trials and the meta-analyses, has been very, very important. So I think it's a combination, not only the literature, but also try it. I think you'll be very happy with the results. But as I said, it's an adjunct to what you're already doing. It's an extra layer that helps push those wounds across the finish line.
Thank you very much to all of you at home who've joined us to have this in-depth look at key specialized topic, which for tonight was topical oxygen. We've done that in 60 minutes with some of the best global experts. We're very keen to bring these key technological advances for you to use alongside your clinical practice. They're all evidence-based. All the links for the papers will be in the chat. And we've had one on November 17th, which you can still watch on demand, which is the pressure injury master series. And the next one we have coming up will be December 13th, and that will be battling surgical site infection. And that's going to be a great panel discussion with, again, the greatest global experts around who'll be answering your questions in an interactive, immersive session. So thank you very much, and we look forward to seeing you next time.